So what we're going to talk about today is sepsis, septic shock, the treatments, things that affect your patients. The cognitive objectives here is we're going to be able to define septic shock and sepsis, recognize the symptoms of both of them, understanding the current treatment, because this is changing a lot. Norepinephrine is the big vasoconstrictor that's used for septic shock. So being able to understand that. What are you going to do if you can't get an IV on somebody that's blood pressure is 50/30? I mean, you got to be able to think about, am I going to IO this patient? What am I going to do? The pre-hospital care for sepsis, and then the role of the paramedic for septic patients. Your psychomotor skills here demonstrate how to prepare the norepinephrine. A lot of places it does not come pre-mixed, so you got to mix it in the field. This is set up for my place of employment, so we use Alaris pumps. So demonstrate how to use the Alaris pumps, how to titrate the norepinephrine to the effective blood pressure that you want. Demonstrate how to recognize sepsis, septic shock, assess appropriate assessment for these patients, and be able to communicate with your partner and whoever. Big thing with this is communicate with the hospitals too. Your effective objectives, advocate for the rapid recognition of signs of sepsis. The quicker we can get onto these signs and start treating these patients, the better the outcome is with them. Importance, again, of recognize for early treatment. Advocate for your patient in a pre-hospital setting, knowing that what you're doing is benefiting them. And then serve as a positive role model for EMS providers. A little bit about sepsis. Affects about 75,000 patients yearly. It's a leading cause of death in critically ill patients. That kills roughly 210,000 people a year. Accounts for about 10% of the ICU admissions. Of that 10% that's admitted, about 50% of those people are going to die. We've just seen in the last, over the years, this has just doubled. And the cases of sepsis has doubled from people with the chronic illnesses, people that's been on these antibiotics for years. It's just they're resistant to it now. And sepsis costs the healthcare industry, it costs about $20 billion. And something I found interesting is the Greek word for sepsis was decomposition or decay. Your pre-hospital, this is constantly changing the care and the pre-hospital setting for these people. I've seen a study that in Seattle that 40% of the severe cases of sepsis arrive by EMS. The rate of sepsis there for them was 3.3 per 100 patients. And I found it interesting, the rate of the STEMI is 2.3, but yet we recognize in the hospital, pre-hospital settings and everything, we concentrate on STEMIs, we concentrate on strokes. Nobody really teaches sepsis. Nobody talks about this is what you need to do. This is where you need to go with these patients and get on treatment early with these people. It's not discussed, and that's why so many people are dying from it. They also say that another study showed that people coming in by EMS with sepsis is a lot sicker than those people that walk in the front door. And, just think the ones that's coming in by EMS, how many of these people are going to die? And if we don't give them that early treatment, then, we're not helping them any. Like I said, this is changing. It's a treatment for sepsis is changing so much. You know, before a matter of time, you're going to see antibiotics, if not already, on the trucks, broad spectrum, that's going to be started on these people. One thing that you want to target with a septic patient is a MAP of 65, and we'll go over that in just a few minutes. Fluids, use of vasoconstrictors. Sepsis was really defined in about 1991. Was a big push for this. They came out with a serious criteria for this. With this criteria, you got to have 2 or more of the above signs in order to classify as sepsis. A temp of between 36 and 38. If it's below 36, above 38 degrees Celsius, which would be 98.6 to 100.4 Fahrenheit, these people that are outside of this range is septic. People whose heart rate's above 90. It's got the fevers. The respiratory rate is above 20. End title's a big thing with these people. Their end title's less than 32. Remember, your average is 35 to 40. The leukocyte count is going to be greater than 12,000, which we're not going to really see that in the field yet. I think that'll be coming. You may still hear the term severe sepsis. It's kind of been eliminated, but you may still come across it with, on graphs, or some of the older providers may still come across it. So just know what they're talking about. So what is sepsis? Sepsis is a life-threatening medical emergency caused by your body overwhelmed response to an infection. Without urgent treatment, this is going to lead to tissue damage, organ failure, and death. Your body has an extreme reaction to the infection. So it's kind of an infection of the blood. Your body's the immune system is trying to fight it off, but it just can't. The immune system, pretty soon, it just pretty much stops fighting, and it begins to attack the normal tissues, organs. And this is leading to the widespread inflammation and leads to septic shock. It has a lot to do with the clotting factors with sepsis. You get the reduced blood flow to different organs. The body causes damages to the organs, and this damage just continues. Eventually leads to organ failure, and that's where the death is falling in. Like I said, it's 1.7 million people a year diagnosed with sepsis. More common in the older people, above 65. We also see them in kids. This is something that you're not going to think, oh, this person doesn't have sepsis because they're 30 years old. Well, no, they can. It can happen. So you just got to be aware of it. There's 3 stages of sepsis, still kind of recognized. Sepsis itself occurs when the body's immune system overreacts to an infection. So then you have severe sepsis, which is causing the organs to malfunction. This is where you usually start seeing your low blood pressure coming in, inflammation throughout the body. Septic shock. This is the extreme low blood pressure. So last stage of sepsis. People's not responding to the fluids. We're using vasoconstrictors, using norepi, dobutamine. There's numerous ones out there that you could start seeing people use on these people. So septic shock is the hypotension and organ dysfunction that persists despite the volume resuscitation. And again, like I said, you may need to add these vasoconstrictors to help with that. Here's kind of the progression of sepsis. In this slide, you see the Sears criteria, which is what I went over earlier. That plus 2 of the Sears criteria plus a confirmed suspected source. So, if we think it's a UTI, or we think they got pneumonia or cellulitis or something like that, that would be considered sepsis. Your severe sepsis is both of those, plus signs of end-stage organ damage, hypotension, so systolics less than 90, a lactic acid is greater than 4, and those vary from site, place to place, what's considered their cutoffs. Septic shock, that's going to be all that. You're going to see end-stage organ, hypotension, the lactic's over than 4. They've been given 1-2 liters of fluid. They're not responding. These people are sick. I mean, you're going to look at these people and you're going to know, oh man, they're sick, they're dying, or they're going to die. Again, your signs and symptoms is your fast heart rate, your fever, or hypothermia on these people too. Shaking, chills, warm, clammy skin. They can be confused, disoriented because of lack of blood flow. They're not getting the oxygen, complaining of shortness of breath, generalized body aches. Here's it's a big kick to know the signs of symptoms of sepsis. Fever, chills, extreme tired, confusion, shortness of breath, lightheaded. I found interesting that on this other slide here, the signs of sepsis, the S, the E, the P, S, I, and S here, all those, just a nice little thing to help you kind of remember what these people are, the signs of it. The lung infection, usually amongst dogs, is 35% of those people come in with pneumonia or something like that. UTI, especially, you kind of see those more in the older people. A gut infection, ruptured bowel. Now they're septic because they didn't come get treatment. There's just all kinds of things like that. Another thing that you may see is a sepsis rash. This first image on the left here, that is an adult with that, and then on the other one would be a child. You may see it, you may not. You may hear them refer to this as a hemorrhagic rash. Like I said, some people you see it, some people you don't. It's just something else that you can you pick up somebody with a rash and you can think, wait a minute, it's not allergic reaction to something. Do I need to be looking here? Let's look at their vitals. Are we seeing they're got some signs of sepsis? Then you need to change your course of treatment to that. So I mentioned, what is the mean arterial blood pressure? That has to do with the average pressure of through one cardiac cycle, from systole to diastole, all the way through. It's diastolic. It's influenced by your cardiac output and systemic vascular resistance. Remember, your cardiac output is calculated by the heart rate and the stroke volume. It affects your preload. Our map will affect your preload, so you're affecting your blood volume, the compliance of the veins. It will increase your blood volume, so it increases your preload, increases your stroke volume, increases your cardiac output. It can even affect the afterload by increasing your stroke volume, and this is causing an increased afterload. Remember that MAP is your driving force for tissue perfusion. Here's the little diagram that shows you the MAP. So, you see your blood pressure in there. The mean arterial pressure is going to be the portion in between. There is a calculation for that, which I'll show you that in just a few minutes. So, concerns with MAP is it's the perfusion to your vital organs. You want that perfusion to be at 65 or higher. When it's below 65, you're starting to get some end organ ischemia, infarcts. When it stays significantly below 65, we're not perfusing the cerebral tissues, so you're getting a loss of consciousness, brain damage from these people. It's causing more organ ischemia to organ failure, more or less. Happens regulation on the cellular level through the complex interaction between the cardiovascular, the renal, and autonomic nervous system. All those come together and has a big factor with the MAP. On the cardiovascular is determined by cardiac output and the systemic vascular resistance. Regulated by a level of intravascular volume, preload, afterload, myocardial contraction, heart rate, conductivity, all this stuff that we thought when we was in medic class, oh, I'll never need to know that stuff. Well, you do. And it's like I said before, sepsis is something that was not taught. You didn't worry about it. The big push was always for cardiac trauma, neurological, and nobody worried about teaching you sepsis stuff. So all those little things that we learned back in medic class of the cardiology all comes into play now. So how do you calculate MAP? There's several different ways that they show you, the third of the systolic and diastolic and all this. Well, who's going to remember that, and who's going to have time to try to figure a third of something in the back of the truck? So the best example I have here would be is 2 times your diastolic plus your systolic, divide that by 3. So example I got here is, we've got a blood pressure 102/38, so 38 times 2 is 76. You get your 76 plus 102 for your systolic, so it comes up to 178. Looks like I miscalculated, mistyped that. It should be 178 divided by 3, which comes out to 59.3. So we're below the 65 here. So with this patient, we're going to want to start fluids on them. Even though that blood pressure is 102, technically they say below 90, but with your MAP is 59, we need to get a jump on that and get that MAP improved to 65, so we're perfusing all those organs. You may see some places telling you the MAP of 60. The new literature coming out is saying that we're going to target that MAP at 65 now. So MAP's function again is to perfuse blood to all the tissues and keep everything functional. The body has some built-in mechanisms to try to help regulate that, but in sepsis, a lot of these things are failing. So your treatments for these, like I said, treatments have changed dramatically over the last 3 decades, and 3 decades from now, they're going to be a heck of a lot different than what they are now. There's been a big campaign that's been kicked off about surviving sepsis. And they target, a lot of that is targeted to the hospital, to the ER and ICU settings. Well, you got to remember, 40% of these patients are coming in by EMS, so we need to get started on it out in the field. If your service doesn't carry a vasoconstrictor, dopamine would not be one you'd want to consider here because of their blood pressures already going to be high. Not their blood pressure, but their heart rate is probably going to be high. Dopamine is going to increase that heart rate. So we're not going to want to really use, that a last case ditch effort. If that's all you got, then a low dose would probably be okay for no longer than what our transport times would probably be. But long term, norepinephrine, Levophed, those are going to be, that's going to be your go-to. Like I said, there's a few other ones that's coming out. It just hasn't quite hit the pre-hospital settings yet. So those would be treatment. Blood transfusions, I've seen some literature about that. I mean, obviously, we're not going to do that in the field, but in the ER could start a transfusion. The ICU is going to be more that long a line, but they're not going to really start that transfusion unless that blood counts below 7. The pre-hospital settings, I think over the course of the next few years, you're going to see kind of like a lactate monitor. The service I work for now, we tried one that kind of puts you in mind of a glucometer a few years ago, and we was kind of finding that the readings weren't, what we was finding in the field was considered high, but then when we'd get in the ER and they would draw one, they're not even close to each other. So obviously some work to be done with trying to get that. You're starting to see services put in the iStats where they can check chemistries. Lactate is one of them that you can check too. It's just a simple blood draw. You put them in a little cartridge, you plug that into the machine, maybe 5 minutes, you get your readings. That's probably going to be something that you're going to see in hospitals or in the ambulance service pre-hospital settings. You probably see it now on the critical care trucks. If you have any interactions with critical care, a lot of them have them now. I think it's going to come down that every service is going to have them. It's going to be the push. It's going to be the standard of care in the next few years, or probably I would say maybe 10 years at the most, but that's going to be the standard of care for ALS services to have this. And like I said before, the starting of broad spectrum antibiotics, it's occurring already in places. Haven't really, whether they're using it for sepsis or more for like open fractures. Some of those people are going to head and starting the antibiotics pre-hospital. The sooner you can jump on that, the sooner the better it is. So what is norepinephrine? Another name for it was Levophed. When I went through medic school, we learned Levophed is leave them dead. Because anybody that was on Levophed, it was time for them to get in the box and move on. You just didn't use it. And if you used it, it was bad. That's kind of, now that's coming back. A lot more people are using the norepinephrine, the Levophed. That's the big push. So it's the most widely used vasoconstrictor in the pre-hospital settings. Mechanism of action, again, this is coming back from the medic school. This is going to affect your alpha and beta 1 receptors. Doesn't really affect the beta 2 receptors or the alpha 2 receptors that much. A low dose, we're talking like 2 mics a minute. The beta 1 receptors be more pronounced. It's going to increase your cardiac perfusion or your cardiac output. When you start getting to a higher level of 3 mics, 8 mics, something like that, you're starting to get more alpha 1 receptors involved. Increase the alpha 1. This is going to help with vasoconstrictions that increase your systemic vascular resistance. So, if you're beta 1, you're going to help your cardiac output. Your alpha 1, this is going to help with the constriction of the arteries. The veins is going to help increase that systemic vascular resistance. Norepinephrine, it's available a couple different ways. It's usually a IV solution, 1 milligram per ml, 4 milligrams, and a 250 ml of dextrose, 5%, or you have 8 milligrams and 250. Like I said, there's some places that it's mixed. A lot of places you're going to get vials. You're going to have to mix it yourself. The half-life of it is like 2.5 minutes. So, if I start somebody and their blood pressure skyrockets right away, you back that down, or if you stop it, within a few minutes, it's going to start coming back down. So you just got to continue to monitor that because a continuous infusion. Our protocol for norepinephrine is an infusion to start to 2 to 4 mics per kilogram. Sorry, 2 to 4 micrograms a minute. And you're going to titrate that up to 12. That's my protocol at Howard. At Clinton County, we go up to 20. So, it just depends. You will see where they tell you it has to be put into a central line. Now, you can use it pre-hospital. Now, it's better if you get an Anacube or even an EJ on some of these people. If we have to do it. Again, if you can't get that IV, what are you going to do? This person's pressure's 60 over 30. They look like crap. The heart rate's 120. They're septic. They're dying. Are you going to drill them and start the norepi? Yeah. You gotta save that life. We get the hospital, we can worry about getting an IV, getting the central lines, things like that. So your norepinephrine is going to come something like this. It's a, here's your vial. It's 4 milligrams in 4 mLs. So like I said, it's 1 milligram per ml. You're going to need like a 20 cc syringe to draw up. If you got to use 4 vials, 3 vials, you're going to need that syringe. You're going to need a needle. This tubing here that I have is for the Alaris pump, which is what we have. Like I said, this is set up for me to teach it here at Howard. This is your 5% dextrose over here. Of course, the IV bag, the one with the blue cap, that's where you're going to plug your tubing in. And then the other one here, the other port, that's where you're going to put your medicine in, okay? And for God's sakes, label your bag. Label your bag. It's just a friendly reminder. You put something in a bag of fluids, you better label it. Because you get to the hospital, it's chaotic, everybody's doing stuff, and the last thing you want to do is forget to tell them, oh, that bag is, norepinephrine, and somebody come along and think it's just D5, or don't look at the bag, think it's saline, and just open it up and blast it in. Here's a picture of the Alaris pumps that we use. There's a couple videos here that I've included that's going to show you the setting up of the pump. On the first video, demonstrate how you turn the pump on, button right there, how to put your tubing in here, and get it all prepared. The second video I have posted here with it is starting the norepinephrine. So that'll walk you through doing that. Very good videos to help refresh your memory. So just to review, the importance of recognizing sepsis, and to recognize and get that early treatment going on these people, getting the fluids. If we're given saline, it tells you that a lot of places it's 30 milligrams per 30 ml bolus per kilogram. If you got that running, and your patient's an elderly patient, good luck. A good chance that they're going to have some sort of probably cardiac history. If they don't have congestive heart failure, is their body going to be able to take 2 liters of fluid? No, they're not. Start that fluid. If they're already drowning before you get them there, I probably wouldn't give them any fluid. I'd go right to the norepinephrine and get that pressure up. We got to get this early treatment. The earlier the treatment, the earlier we recognize these people are sick, hopefully the better outcome. That 10% of the ICU admissions with 50% death rate, I sure wouldn't want to be one of those people. Um, Also alerting the ER early. Hey, you know what? We're bringing in a septic patient. They're finding that they're getting better outcomes on people that we have alerted them early that, hey, I gotta highly think this is a septic patient. They got 3 of the 4 symptoms or serious criteria. I've started norepinephrine on them. All them things. It helps. They're finding better outcomes with these people. So just remember, there's roughly 210 people die yearly from sepsis. So, hope you guys enjoyed the video. Hope it was helpful. Good luck to all of you.